Hello, let's talk about pulmonary shunting. And there's probably no more important topic than this right here when we're talking about the practical application of issues that involve patients and taking care of patients. And pulmonary shunting is very common where patient care is concerned. So we should talk about the physiology of it. And pulmonary shunting is broken down into a couple of different categories. And we'll try to sort through those. The categories that we're going to talk about are absolute shunt and relative shunt. Absolute shunt is basically absolutely what's all the shunting that's taking place, and then we'll address relative shunt as we go along. But we'll delve into this and kind of be more specific about which type of shunt causes what and that kind of thing. So shunt in general, though, is blood that bypasses the lungs without gaining oxygen. That's kind of what this is saying, that if the blood goes from the right side of the heart to the left side of the heart and never gains oxygen, that is what shunt. That's what shunt is, and we'll talk about more as we go along here. Absolute shunt, one of the anatomic shunt is when blood flows through the right side of the heart to the left without coming in contact with the areas of gas exchange. And this is talking about the old book, so we should realize that if you're in the old book, it's on 253 that we're talking about these 252, 251, 2 and 3 is the old book. And then in the new book, it's talking about pages really 280 through 283. Those are the areas you'll find this in the book, and you should really read this over and over until you get a good handle on it, because it's really important and it's a test. A lot of this is on the test, so please be aware. It's not a very good picture up here, but this picture is in your book. 253 in the old book, 282 in the new book. And this picture is showing the different types of shunting, and we'll go through those. All right, so let's take these on and start with first things first. This is a normal alveolar capillary unit, and what we would like to see is that blood flows past a ventilated alveolus, and deoxygenated blood becomes oxygenated blood because it passes an alveolus and diffusion occurs, and things are looking good and going well. But there are anatomic shunts, basically are a part of your anatomy, that in situations where blood may bypass the lungs without gaining oxygen, and then you have venous admixing over here, where you have venous blood mixing with arterial blood. Now, this is normally and naturally occurring, and one of the examples of this is the Thebesian veins. Those are veins that drain their deoxygenated blood directly into the left side of the heart. Thus, it's not a perfect system, and sometimes the oxygenation, or normally the oxygen saturation is lower than it's not 100% saturated, and so that would account for why that is. So anatomic shunt, if you want to think of it as part of your anatomy, that's a good thing to do. Now, these are the causes of anatomic shunt, or part of your normal circulation. Can there be abnormalities that contribute to anatomic shunt? Yes, there can be. What are they? These are the things that would fall into that category. In congenital heart defects like ventricular septal defect, the blood may shift from one ventricle to the other and cause there to be venous admixing or things like that. So the blood may bypass the lungs in that way. This is congenital heart defect is usually the culprit there. Intrapulmonary fistula, the book talks about this happening when there's kind of trauma or something to the lungs. And then vascular lung tumors. Anytime there's lung cancer, remember that lung cancer is those tumors are, they have lots of blood vessels, and so the blood may take the route of going through those blood vessels in the tumor as opposed to going past an alveoli and contributing to anatomic shunt. So these are the abnormalities that contribute to anatomic shunt, but anatomic shunt exists normally, and we said that the normal shunt percent, you could say the normal anatomic shunt percent is 2 to 5% normally, and maybe even as much as 10%. But anything above that would be considered abnormal, and we'll talk about that. Capillary shunt, this is the one we're going to really focus on. Anatomic shunt and capillary shunt are really the ones I need for you to know well, very well. Capillary shunt is also called intrapulmonary shunt, and it results in refractory hypoxemia. Now, just to review, refractory hypoxemia is, if you gave it some kind of criteria, it would you would say that refractory hypoxemia is a PaO2 of 60 millimeters of mercury or less on an FiO2 of 60 or more. So if you keep turning the oxygen up and the P little AO2 does not respond, then you have refractory hypoxemia, which means there is a diffusion problem, which, you know, in most cases or many cases means there's capillary shunting or intrapulmonary shunting. You hear these terms used very frequently. All right, common causes of this, and you see this figure in the old book at 612 and figure 614 in the new book, but you basically see a fluid accumulation in the alveoli, which could be pneumonia or pulmonary edema, and then you see, the fluid accumulation is pulmonary edema. Consolidation would be pneumonia, and then obviously atelectasis. Any of those would contribute to capillary shunting or intrapulmonary shunting. Now, these are indications in many cases for CPAP therapy. So this is how you treat intrapulmonary shunt, by trying to force open the alveoli with positive pressure. So if you look at the indications for CPAP, or later on you'll hear the term PEEP. CPAP is continuous positive airway pressure. PEEP is positive end expiratory pressure. The indications for those therapies are things like pulmonary edema and atelectasis. So very relevant issues that we should be talking about and addressing. Okay, so here's capillary shunting. Basically, you have a collapsed alveolus. You notice that the bloodstream is blue, and it doesn't ever change colors because this blood doesn't pass an alveolus that's ventilated, and it doesn't get oxygenated, and that's a problem. Okay. Then we can talk about shunt-like effect, which I want you to focus on hypoventilation as being one of the causes of shunt-like effect, and essentially that if the patient's not breathing in and out effectively, then their oxygen level is going to go down as well as their CO2 level going up. Okay, picture of relative shunt or shunt-like effect: decreased ventilation, high CO2 and low PO2. Those things oftentimes go together, and so anytime the patient's not ventilating, they're also not going to be oxygenating. Okay, common causes of this form of shunt: hypoventilation. I said that, so you should think in these terms. Mixed venous blood. This is where we were talking about. You have a good alveolus where good diffusion. You see all this red where there's good oxygenated blood, and then you have a bad alveolus where there's low oxygen and then you have a mixing of the two, which is venous admixing. All right, the significant levels here, we make sure that you realize that basically any intrapulmonary shunting of 20% or greater is critical, and we said maybe up to 10% might be normal, but typically 2 to 5% is what we're going to be seeing for normal shunt. Just a reminder that we use the 8A gradient to find the shunt percent by taking saying that every 100 of the 8A gradient is equal to 5% shunt plus 5% added back for the normal shunt. Two critical numbers that you want to know here is that an 8A gradient of 300 is critical, and a QSQT or shunt percent of 20% or greater is critical. That's a lot to take in, and we'll leave it at that. That's us talking about the types of shunting, and just let me know if you have any questions. Please get in touch with me, and we'll talk about any questions or issues that you have. I appreciate your attention. Thanks.